It is not unusual to have these perimenopausal fluctuations in the 40s. And so many women think that if they bring up that they need a vibrator in order to have an orgasm, that somehow the guy's going to be insulted. And quite frankly, it's the exact opposite. Now, as far as perimenopausal symptoms, very similar to what a lot of women are going to experience in menopause: insomnia, brain fog, hot flashes, vaginal dryness. But what differentiates perimenopause from menopause is that.
Welcome back to the Rena Malik MD podcast, your source for evidence-based information about your sexual health and more. Today, our guest is Dr. Lauren Streicher, Clinical Assistant Professor of Obstetrics and Gynecology at Northwestern University. You've seen her on the many popular TV shows like The Dr. Oz Show and The Today Show, all championing women's health. She is the host of her own podcast, Dr. Streicher's Inside Information, as well as a new mini podcast series called Come Again. We had a wonderful conversation about perimenopause. We get down to the science of why it happens, what causes it, and how you can treat it, both with hormones and without. We also talk about things all women want to know, including how to manage weight gain, lack of sleep, and hair loss. And of course, you can't leave this podcast without talking about sex, particularly sex after menopause, what to do about painful sex, and difficulty with orgasms. Now, in today's conversation, we started off by talking about how menopause seems to be having a moment.
It is funny how they say menopause is having a moment, as if this is a brand new thing, when in fact, of course, women have been going through menopause forever. And I've been talking about it for decades. And I think what's really changed, sadly, is that people have seen an opportunity for a lot of money to be made, particularly when you look at celebrities and influencers. There's a lot of bogus products out there, a lot of people that are just basically selling menopause. And that also leads to all kinds of problems.
I agree with Dr. Streicher in that while I'm happy menopause is getting some well-deserved and needed attention, there is a bit of fear and hysteria around menopause, with women sort of starting to become even fearful of the future. And in my opinion, the best way to ease those fears is to discuss the science. So I asked Dr. Streicher, how do you separate perimenopause symptoms from the regular symptoms that we're often struggling with in midlife, whether it's working, dealing with relationships, children, aging parents, everything that's going on in midlife?
It's very unfair that perimenopause hits right at this moment in life when you do have all these things going on, but that's the reality. Well, let's start by defining menopause to put it in context. Menopause is when you're no longer producing estrogen. Period. It may be because your ovaries have naturally decided that they're done producing estrogen. It might be a result of surgery if you've had your ovaries removed, chemotherapy, radiation. But leading up to that period of time when your body is no longer producing estrogen is perimenopause. And a lot of people think that you start where your estrogen levels are high, like when you're 20, and then they just gradually decline. And that's not what happens. Perimenopause, which is preceding menopause, is a period of time when hormones are fluctuating. I call it the perimenopausal roller coaster. And the only thing predictable about perimenopause is that it's completely unpredictable. Just when you think you're done with your periods and you get on an airplane wearing white, boom, there it is again. Just when you think these hot flashes are never going to go away, they go away. You think maybe it was the black cohosh, and then they come back again. And it's because your hormones are up and down and all over the place. And in terms of when it hits, that's a real surprise for most women, because everybody thinks about perimenopause and menopause as being something that grandma experiences, as opposed to women in their 40s. Now, the average age for women to no longer produce estrogen is 51, but that's average. It can also happen in the mid 40s or even the early 40s, which means that perimenopause also hits earlier than people expect. And it is not unusual to have these perimenopausal fluctuations in the 40s. As far as how long this all lasts, well, on average, 4 years. Some people longer, some people shorter. And if you enter a surgical menopause, meaning removal of the ovaries, you do not experience perimenopause. You don't have any of those fluctuations. You go right from high estrogen to low estrogen. Now, as far as perimenopausal symptoms, very similar to what a lot of women are going to experience in menopause: insomnia, brain fog, hot flashes, vaginal dryness. But what differentiates perimenopause from menopause is that because your ovaries are still producing estrogen, you may still get a period. You may even still get pregnant, generally only if you don't want to, never if you do want to. And that's what really differentiates perimenopause from menopause.
I then asked, why does the space of perimenopause even exist? What is the physiologic basis behind it? And why does it even happen?
I mean, certainly we can explain it biologically what's happening because you're born with millions of eggs. And what people don't realize is that the follicles that the eggs are in actually produce hormones. So as the eggs age, then you're no longer producing these hormones, but there's a lot of these eggs there. And that's why these levels go up and down. And that's why it is such a confusing time. As to why this happens, I can't explain why. We just know that it does.
We're hearing a lot on social media about something called estrogen dominance. Now, Dr. Stryker tells us a little bit more about the science behind how estrogen changes during perimenopause and where this came from.
When we were in medical school, you don't find those words in any textbook or any lecture. It's one of those things that you hear for the first time when someone on social media and you're like, did I miss that lecture? There is no such thing as estrogen dominance, but it is very popular out there on Instagram and TikTok for people to be talking about that.
Now, estrogen dominance essentially refers to the time in perimenopause when estrogen is just higher than it should be, which occurs periodically, and it can lead to symptoms that are correlated with a higher level of estrogen. So, one might ask, should I be tracking my hormone levels all the time so I can know when these periods are? Is there actually any value in that?
Not only is there no value, but it can be incredibly misleading. I've gone on and on about these home menopause kits, which are completely worthless because basically what a home menopause kit measures is FSH in the urine. And people say, is it accurate? And I'll say, yeah, oh, it's accurate. It can tell you if you have FSH in the urine, which goes up in menopause, but it's not meaningful because those levels fluctuate. So if you do a home menopause kit at 2 o'clock on Tuesday and it shows that your FSH is high, you're going to read that as, nope, you're fine. You are not in perimenopause. You're not in menopause. And then you crash 2 weeks later. So it can really throw people off. And as old school as it sounds, the best way to diagnose perimenopause is for me to actually talk to someone, to ask them, what symptoms are you having? When was your last period? Let's talk about your medical history. How old are you? All of those things put together are more often than not going to tell me if someone's perimenopause or postmenopause. Do I ever get hormone levels, blood hormone levels? Yes, I do, but it is not necessary to do it routinely. Menopause experts don't do it routinely. We do it if it's really going to help us figure it out. And this is the important part. Those levels must be interpreted by an expert. So a lot of women will go to their family doctor or to even an OBGYN or their internist and say, hey, I think I'm in perimenopause. Will you do a blood level for me? So just to, be nice and say, sure, I'll do a blood level for you. And then they call them up and say, nope, you're not in perimenopause. Your estrogen level is just fine, when in fact it was that day. But they didn't know how to interpret these tests as far as timing, does it need to be repeated, and in the context of everything else that's happening. But those home menopause tests, don't bother. One of the things that's confusing is for the woman who doesn't get menstrual periods. And we forget about those women. We always say that menopause is when you haven't had a period for 12 months. Well, if you have a progesterone IUD, maybe you haven't had a period for 3 years, but it doesn't mean you're in menopause. Or if you've had a hysterectomy, you can have a hysterectomy, and that's not going to put you in menopause if your ovaries were not removed. So women who might have a hysterectomy when they're 35 or 40, they don't have menstrual cycles. People who have uterine ablations, who have heavy bleeding, they don't have menstrual cycles. And in fact, those home menopause tests will even tell you in the small print, if you don't have a menstrual cycle, if you've had a hysterectomy, do not buy this kit. So it is a little bit more challenging, if you will. But the other way of looking at it is it doesn't really matter. We don't have to label, are you perimenopause, postmenopause, or what pause you're in. I want to know what symptoms you're having. And then I'm going to help you deal with those symptoms without necessarily putting a big stamp on your forehead that says you're in perimenopause or postmenopause.
Dr. Stryker then tells us the early signs that people might expect when they're experiencing hormonal fluctuations that are consistent with perimenopause.
For women who do menstruate, generally the first thing that's going to happen is their periods are irregular. And again, this can be confusing or misleading because there are many reasons to get irregular periods, particularly in the 40s. Sometimes it's thyroid dysfunction. Sometimes it's stress. Sometimes it's rapid changes in weight. Sometimes it's for no reason at all. You're just not ovulating regularly, but it doesn't mean that you are crashing into perimenopause or menopause. But that is generally the first thing that you're going to see. And in fact, if a woman comes to me and says, hey, I don't feel like myself, I wonder if I'm in perimenopause, the first question I'm going to ask her is, are you getting regular menstrual periods? And if she says yes, then it's not impossible, but it's unlikely. Now, the other thing is defining a regular menstrual cycle. A lot of women say, okay, well, I get a period every month, but if some months it's 26 days and some months it's 30 days and some months it's 25 days, from our point of view, that's actually not regular. That tells me that she's not ovulating regularly or at all. And that may be an indication of perimenopause. This is the same reason why women who are trying to get pregnant in their 40s have so much difficulty, because not only are the eggs not as good, they've aged, but also they're not ovulating regularly.
We also commented on the duration of perimenopause and why some women claim they experience these symptoms for up to a decade or 10 years.
Well, first of all, it hasn't been well studied. The other thing is that there are a lot of women that say, I've been in perimenopause for 10 years, and they're really not in perimenopause, just because they don't have regular periods, or maybe they're having some symptoms which they're attributing to that. It's kind of like when people say I have PMS all month long, well, then it's not PMS. So I think we have to be really careful when we hear about people who say I've been perimenopause for 8, 9, 10 years, because that's typically not what happens. For most people, it's really that 3 to 4 years. And we don't know why it is that some people start to wind down a little earlier and that it might take a little bit longer.
I asked her, what are some ways one can predict if they're going to go into perimenopause earlier or later than average?
That's $1 million question. And a lot of people have studied that. One of the greatest predictors, quite frankly, is when your mother went to menopause. If she was on the early side, it's not a given, but chances you may be on the early side as well. If your mother menstruated until she was in her mid-50s, then that's an indication that you might. We know there are certain specific things that will have people go into menopause early. So as an example, people who have autoimmune diseases like Hashimoto's thyroiditis or lupus or something like that. Smokers. I mean, smoking's bad in every way you think of it, but smokers also can cause an early menopause. When you look at people who just have a lot of different chronic illnesses, that can also cause an earlier menopause. But the number one predictor is going to be genetic. Now, the other thing is, well, how about, is there a blood test? If you were to say, is there any way we would know? And the answer is sometimes. This FSH level that I mentioned is really not useful because it bounces around all the time. But there are some other blood tests that can sometimes be done that we really learned about from the fertility world, looking to see if people were continuing to be fertile. But again, these are not rock solid indications. They're all just pieces of the puzzle that all contribute to what's going on. At the end of the day, no, I can't tell someone when they're going to go into menopause.
Dr. Stryker also shares with us what will and won't help in terms of reducing the severity of these symptoms during perimenopause.
I will start off by telling you what is not going to change anything. Doing yoga, doing supplements, all that kind of stuff is not going to do a thing. I mean, obviously, it's really important midlife that people really pay attention to their health in general, to get to a healthy weight, cut out the processed foods, cut out the alcohol, all of that. But I would say, regardless of when you go into perimenopause or menopause, those are all things that women should be thinking about doing. So there's nothing that someone can do in advance that's really going to change their experience. But having said that, if someone starts to have bothersome symptoms, it is never too soon to talk to a menopause expert to see what they can do. One of the many myths, while we're on the subject of myths, one of the many myths out there is that you have to go 12 months without a period before you can do anything to help with your symptoms. That is so not true. And in fact, it's incredibly cruel to tell women, I know that you're not sleeping, your vagina's like the Sahara Desert, you're having flashes like crazy, and you can't remember why you walked in the room, but oh, well, this has only been going on for 3 or 4 months, and you had a period 5 months ago, so we can't give you any treatment until you're a year out. That is absolutely not the case. We do both hormonal and non-hormonal things during perimenopause that are going to smooth out these crazy hormonal fluctuations. And the approach really is very much about what symptoms someone is having. So, for example, if someone is having all kinds of crazy, unpredictable period problems, they never know when they're going to bleed. It comes, it goes. They're having hot flashes that come and go. Believe it or not, the best thing that we can do for you is to put you on a low-dose birth control pill. And a lot of women who don't understand the rationale behind this will say, oh my God, I went to my doctor and they just wanted to put me on a birth control pill. And the reason that we do that and that it is helpful is because these crazy fluctuations in perimenopause, what we really are trying to do is say to your ovaries, you know what, you seem a little bit confused. We're going to take it from here. You guys go on a rest, and we're going to give you estrogen and progestin hormone therapy in the form of a birth control. It's still hormone therapy, but it's a little bit higher than what we give postmenopause to basically take control of the hormones in your body so that you get a very consistent amount of estrogen and progesterone every single day. You know, it's suppress and replace. And for a lot of women, this is the best way to make it through these perimenopausal hormonal fluctuations, because not only is it going to control irregular bleeding, hot flashes, sleep, and all of that, but it is also going to provide contraception for people who that is still an issue. And most women can safely take birth control unless they've had a history of a blood clot or something else that really contraindicates it. And if they're doing well, they can stay until age 55, which always surprises people. And the reason we pick age 55 is because at age 55, 95% of women are done with this fluctuating up and down period. They are clearly postmenopause, no longer making estrogen. And then we can take you off of your birth control pill and put you on hormone therapy, which is dramatically lower dose. Everyone always thinks it's the opposite. Isn't that funny? They're like, they're on a birth control pill, and then you say, okay, well, I want you to take hormone therapy now. And they're like, oh no, that's dangerous. And it's like, oh, no. It's the birth control pill that is dramatically higher and that has a higher risk than hormone therapy, which is very, very low dose. And it's just to get rid of symptoms, not to suppress your ovaries.
She also talks about why one would consider oral contraceptives rather than standard hormone replacement therapy, specifically during that perimenopausal time period.
The hormone therapy is not going to be high enough, because what's happening is so many of these symptoms are not from your estrogen being low, it's from the fluctuation. And if you just give someone a little drop of estrogen, those surges that people get, it's not going to control it. And that's the problem, is this idea, well, maybe I'll just take a little estrogen to smooth me over. It's really, for most cases, not going to get you anyplace. The one exception to that is if you have someone who's had a hysterectomy or, some other situations, sometimes you can just give them a little bit of estrogen and they'll be fine. But for most people, a little hit of hormone therapy is just not going to suppress those fluctuations.
We also discussed how cognitive changes or brain fog can be correlated with the symptoms of hot flashes.
We know that there's a very high association with people who have hot flashes and who are also having brain fog. And this is multifactorial, because part of this is if you are having hot flashes, you're not sleeping. And we know that if you don't sleep, that in and of itself is going to impact cognitive function and brain fog. But they have now found, and this is actually newer information, that even in the absence of hot flashes, there are still neurologic changes in the brain that can cause brain fog. What a lot of people don't appreciate is that there are estrogen receptors in the brain. Everyone thinks estrogen receptors are just in the reproductive organs. No, they're everywhere. They're in your muscles, they're in your skin, they're in your joints, and then they're in your brain. And basically what's going on with brain fog is your brain is getting used to the new normal. And that's why it's temporary. The brain is amazing in how it can recalibrate, how it can adjust. And so the good news about perimenopausal brain fog is that, number one, it's temporary. And number two, it is not an indication of dementia down the road. And that's really important for women to know, because when they go through perimenopause and they suddenly can't remember what they were in the middle of doing or why they walked into a room, and they think, uh-oh, this means I'm at high risk for dementia or it's Alzheimer's. And that's not the case. That's not the case. So when you think about, okay, what can you do about this brain fog other than ride it out? And we've already talked about this, could be sometimes as 3 or 4 years. So not a good plan to ride it out, because aside from not being able to function in life, you won't be able to function in work. We have very good data about the impact of menopause, brain fog, cognitive issues on your ability to do your job. So this is not something you just want to say, okay, whatever. We do know that, number one, getting a decent night's sleep is going to make all the difference in the world. And during perimenopause and early postmenopause, that's not so easy. We know 60 to 70% of women have sleep disruption. Part of it is because of the hot flashes, but it's not entirely because of the hot flashes. Things like restless leg syndrome, sleep apnea increase, and then the thing that a lot of people don't realize is from hormonal changes, joint pain. The changes in the joints, there are also estrogen receptors there, cause people for the first time to have maybe arthritic symptoms, or if they do have arthritis, they're going to get much worse. They can't get comfortable. They're tossing and turning all night. There's the snorer in the bed with you. There's a lot of reasons that women are not sleeping. So number one is always, we got to get you to sleep. That's going to help your brain fog. It's going to help your cognitive function. And then we have very, very good data that shows that hormone therapy, either in the form of a low-dose birth control pill, or if someone's already at that point, to give standard menopausal hormone therapy, will mitigate the brain fog. And for many women, that's the primary reason why they're taking it. It's not even because of vaginal dryness or hot flashes. It's so they can think, so they can work, so they can function.
Dr. Stryker also shares how the cognitive changes, often called brain fog, can really seriously affect women during this transition.
1 out of 4 women consider leaving their jobs during this period of time because they're not functioning, they're frustrated, you get anxious, you get depressed, all of that. And it shouldn't be that way. We need to talk about it as we are now so that women appreciate that they can get help. And a lot of women out there are thinking, okay, well, I don't want to take hormone therapy, or maybe they can't for whatever reason. And we have non-hormonal options too. There's wonderful non-hormonal options to get rid of hot flashes. There are things we can do to help people sleep. Even cognitive behavioral therapy has been shown to be really, really useful. So we have a lot of tools in our toolbox. And if someone hasn't given you one of those tools, it doesn't mean it doesn't exist. It means you need to see an expert. And that's the other big point is, so often when I do interviews from the media and they're like, oh, so women should talk to their doctor. And I'm like, well, she could, but more often than not, their doctor's not going to be helpful, because unless she's lucky enough to have a menopause expert as a doctor, most of them have not been trained. Most of them don't have this information. And it's kind of strange because unlike other situations where they'll refer you, they don't. I mean, if a woman goes to her gynecologist and is having difficulty getting pregnant, they're going to get referred to a fertility specialist. If she has cancer, they're going to get referred to a gynecologic oncologist. If they're having terrible incontinence problems, they're going to get referred to, urology or urogyn. And then they're having menopause and it's like, oh, well, I'll tell you what to do. And it's like, really? You're really not getting that right.
We also discussed the causes of weight gain during menopause.
When you look at weight gain midlife, there is absolutely weight gain, and men gain weight too, but women gain more weight. And when you say things like lifestyle, like, oh, you're not eating well or you're not exercising as much, well, that's true for the men. So why are women gaining more weight? Well, it is because of these hormonal changes. We know that metabolism does change as a result of hormones. We talked a little bit about sleep. In addition to all the other bad things sleep can do if you're not getting enough of it, we know that if you don't sleep, you're going to have a very hard time maintaining a healthy weight, because the hormones that get totally thrown off if you don't sleep are the leptins and the ghrelins. And that is what's going to control not only your appetite, but metabolism. So women have like 12 different reasons why they're gaining weight. Part of it is because of the change in hormones, and then they don't sleep, which is going to throw off their leptins and ghrelins. And then because you don't sleep, you make bad food choices, and then you don't get the activity that you need to get. And it just goes on and on and on. The other thing that happens is alcohol. And alcohol is a huge factor, because so many women, if they can't sleep or if they are stressed, what do they turn to? They turn to alcohol. And in addition to all the other problems with alcohol, there's a lot of calories in alcohol. And I cannot tell you how many women who are struggling with their weight. And when I say, by the way, how much are you drinking? And they're like, well, my 2 glasses of wine a night has turned into 3 glasses or 4 glasses. That's a lot of calories over time. So really my approach to weight gain and menopause is, number one, you got to deal with the sleep. You got to deal with the hot flashes. We know that hot flashes also are associated with weight gain, because every time you have a hot flash, you have a little surge of cortisol. And that cortisol is also going to impact on metabolism. Obviously, you have to make sure that someone is eating healthy, cutting out the processed foods, paying attention to alcohol and all of those things. It's challenging because not only are you gaining weight, but you have a redistribution. Even women that don't gain 1 pound, suddenly it's like, hello, where did that muffin top come from? And you're not imagining it. It does happen. And there's only so much you can do. I mean, part of it is a little bit of acceptance. And I'm not saying you should accept an extra 20 pounds because at the end of the day, that's not healthy. But if you are up 2 or 3 pounds, or there's been a bit of a redistribution, that's what Spanx are for, right? But we also have to be a little bit realistic, and part of it is aging. A lot of times it's blamed on slowing down metabolism because of aging, but there's really been some very good studies which have shown that metabolism does not slow due to aging until closer to 60 or 65. And most women are experiencing this weight gain as their hormones are fluctuating.
He also explained why women tend to start noticing hair loss during this phase of life.
Hair loss, androgenic alopecia, meaning that it's basically a male pattern kind of hair thinning that we see in women as they go through menopause. So suddenly if your part's a whole lot wider, or you're seeing a little bit of decreased hair right at the temples, and just overall things are thinner, you are not imagining it. That is absolutely something that about 50 to 60% of women experience. Some of it is genetic, but a lot of this is hormonal. So in terms of what's actually going to work, well, let's start with what doesn't work. Supplements do not work. I actually have a couple podcasts on this, and I did one on Nutrafol specifically. The Nutrafol people are not very happy with me because I did a very deep dive into their so-called science and literature, and in fact, it does very, very little, if anything. Biotin, all of those other things, they just really don't help. It doesn't make a difference at all in terms of increasing your hair. What does help is minoxidil. The topical minoxidil, sometimes mixed with finasteride, will help. This is something that has to be compounded with the finasteride, although you can get minoxidil topical over the counter. The problem with minoxidil is it does work, but you have to be consistent with it. You have to keep up with it, and that's very difficult to do. So what most dermatologists, the hair specialists, are recommending is oral minoxidil. Now, oral minoxidil works very, very well in terms of helping with hair loss in this time of life. This is an off-label way to use minoxidil. Minoxidil was actually developed as a blood pressure medication, but like a lot of other drugs, we find that it has other uses. And so a very, very low dose minoxidil, which does require a prescription, can help dramatically with hair loss. The downside, there's always a downside, is that you're also going to get some hair growth other places you might not want it, facial hair growth. So you have to decide if you want to deal with that. But that usually is your best bet. But it is a very common thing. And then, we know stress doesn't help as far as hair loss. So again, getting to sleep and all these other things that cause stress. So that has to be dealt with too. And then there's the over drying of hair, blow drying products, tight ponytails, all of those things contribute. But if you look to the hormonal aspect of it, that is something that absolutely is real, and it hits people, and there are things you can do about it.
Now, Dr. Stryker did some sleuthing on the very popular supplement Nutrafol, and let me tell you, it was thorough.
One of the things I did is, how Nutrafol has different formulas, under 45, over 45. So I looked at labels, the under 45 label and the over 45 label, and at first glance, it looks like they're very different. It's all the same ingredients. They put them in a different order. Very clever, so that it looks like it's a different formula, but it's not. The other thing is, when I looked at the references they give for over 45, there are none. So all of these claims that they make are simply not true. There's only been one study of Nutrafol in people over age 45, and we're talking one study that shows there's an average of 7 additional hair follicles per centimeter, so about half an inch. When I figured this all out, and I contacted the Nutrafol people, and I said, I just want to make sure that I'm calculating this correctly. Check my math. According to this study that shows 10% increase in hair, and there's an average of 50, 60 follicles, per centimeter, is it true that that's what you're getting for Nutrafol? And they said, yes. I have it in writing, they said, yes, your calculations are correct. And then when you look at the cost of it, well, Nutrafol is expensive. It's almost $1,000 a year. And if you stop using it, you lose whatever benefit you get. So if you think about women becoming perimenopausal about age 45, and then they live until hopefully in their 80s, and they still want to take the stuff to keep their hair going, we're looking at over $30,000 for a lifetime cost of Nutrafol, which is an awful lot for 7 additional strands of hair, as opposed to generic minoxidil, which is about $2 a month. So something to keep in mind. The Nutrafol people aren't happy with me, but the facts are, it is what it is. And I went through and I looked at every single article, and I can guarantee you that 99.999% of dermatologists that are recommending Nutrafol have not looked at their literature because it's not easy to find. It's on the website, it's teeny print, nothing is hyperlinked. I had to look up this stuff. Half of this stuff is stuff that's so old, it was long before Nutrafol was invented, or it has nothing to do with hair. I mean, it looks so credible when you see these sources on the website until you actually start to look them up.
While she didn't look at the literature in men, I suspect the findings would be relatively similar.
I have to admit, I did not look at the literature in men, but I absolutely guarantee you that it's going to be no different because of the studies that they list. Most of them didn't even apply to hair. Honestly, it was skin. It was crazy stuff. And so, but they, it's advertising, it's marketing. It's like everything else. Take this stuff. Your hot flashes are going to go away. Your hair is going to grow. Your vagina is going to lubricate. And the truth is that most of these things are non-FDA approved, they're over the counter, and therefore they do not need to prove their claims. They can say whatever they want, so of course they do.
We also discussed what dietary changes you can make to help ease the symptoms of perimenopause and menopause.
Well, it depends what you're trying to accomplish. If you're talking about helping with hot flashes, what we do know is that there are some foods that seem to be triggers. For a lot of women, red wine is an example. Spicy food will cause a hot flash. But my approach is, okay, don't avoid the spicy food. Do something that's going to get rid of your hot flashes. But if you were to say, do people that have, say, a plant-based diet or that eat healthier, are they less likely to have hot flashes? The answer is no. It's so funny because you sometimes have someone who says, well, I've never had a hot flash, and that's because I eat clean and I do yoga. And it's like, no, it's because you're lucky. You're just lucky. We know 20% of women never have a hot flash, and it's more genetic than anything else.
Dr. Stryker then reviewed the non-hormonal options for menopause symptom management.
So hot flashes is the big one. And so you say, okay, we know that the gold standard is estrogen, and that estrogen is going to get rid of those hot flashes. It's safe. It does not cause breast cancer. Most women can take it, even, if they've had medical problems. But having said that, there are women who prefer not to take estrogen or have been told not to take estrogen. So there's really a couple of options to get rid of those hot flashes. Number one is there's a drug called fezolinetant. The trade name is Veozah. And basically, this is a drug which is not estrogen, but it works on estrogen receptors in our thermoregulatory zone, meaning our internal thermostat in the brain. And fezolinetant will really take away those hot flashes. It's a pill. It's a daily pill, and it will basically get your internal thermostat working again because it tricks it into thinking that it's estrogen when in fact it's not. And if people say, okay, well, why not just take that instead of estrogen? If it's a non-hormonal. And the answer is it helps your hot flashes, but it's not going to help your bone, your vagina, your joints, anything else. This is just for hot flashes. So that's option number one. The other option, which is actually the go-to for a lot of women, is to use an antidepressant. We know that antidepressants, particularly the SSRIs and the SNRIs, in very low doses will help with hot flashes, either getting rid of them or making them less intense. If you can get someone who has severe hot flashes and make it mild, that's going to go a long way. The problem with the SSRIs is that, first of all, they don't work as well as estrogen. But a lot of doctors who are not comfortable with estrogen will use that as their go-to. And for some women, it's great and it works well for them and it's terrific. But for other women, number one, it's not going to work that well. But we're also seeing this huge impact on sexual function. The SSRIs can get in the way of libido. They can get in the way of the ability to have an orgasm. And they can also, for some women, cause weight gain. So while it's not my first choice, for most people, it is when you look at what a lot of clinicians are prescribing out there. Women are not being given the option of hormone therapy. They're just being put on an SSRI. And there are statistics that show that as many as 1 out of 3 peri and postmenopausal women are taking an SSRI. And I'm not talking about women that were on an SSRI prior to perimenopause and that they, it's very helpful to them in terms of managing their anxiety and their depression. And we don't want to take that away. We'd never touch that. I'm talking about women who are not having issues with anxiety or depression, but are having menopausal symptoms like hot flashes and anxiety and palpitations, specifically because of hormonal fluctuations. And instead of being offered hormone therapy, they are automatically put on an SSRI. So it's an option. It's kind of wild. And again, I don't want to make it sound like it's not helpful to anybody. For a lot of women, this is extremely helpful. It's the answer, and they feel great on it. But there are those women that they're trading one thing for something else. And for many of these women, it is sexual function. Now, a lot of people ask about things like black cohosh, right? That's very popular. But one of the things that makes it really tricky to study these supplements is that there's a huge placebo effect. And the placebo effect, of course, is real. If you give someone blue M&Ms and you convince them that it's going to take their hot flashes away, it will. But it's not sustainable. We're looking at, so placebo effect is what, 12 weeks, 16 weeks at best. And if hot flashes only last 12 weeks, that would be fine. And if you look at all the studies that look at black cohosh, and there's a lot of them that show that it helps, but take a look at those studies. They don't go past 12 weeks. The only studies that are really going to count are the ones that are long-term. And in fact, this was a study that was done, it's not that recent, we're looking 10, 12 years ago, that looked at black cohosh over 52 weeks, and it stopped working right about week 12 or 14. So that's something to keep in mind. When women say, well, I tried it and it worked for me, I'm sure it did, but it's just not going to work for long. Or, my doctor recommended black cohosh, and it's just the data shows that it's really not going to work.
Dr. Stryker also shared options to help with sleep, the hardest thing of all.
I think the first thing is to really figure out why you're not sleeping, because again, everyone attributes to menopause. We know that sleep apnea increases significantly post-menopause, and the reason for that is same old story. You have estrogen receptors in the epiglottis and in the back of the throat, and so we see this increase in sleep apnea in women right around the time of perimenopause and postmenopause because of these hormonal changes. Now, when we think about sleep apnea, which is periods of time when you're sleeping, when you actually stop breathing for very short periods of time, people associate it with snoring, which is true, and they associate it with having obesity, which is true. But we also see it in women who don't snore and who are at a healthy weight. And sometimes the only sign that someone's going to have of sleep apnea is that they have a morning headache. See this in women much more than we do in men, and constant fatigue. Even if you feel like you sleep, you're tired all day long. And then we have restless leg syndrome that has very specific treatments, and then all of those aches and pains. So really, the first step, especially if someone is not having hot flashes, is to get a sleep study. Find out why you're not sleeping, because then you can target the reason and offer treatments that are specific to that problem. If someone has sleep apnea, you got to treat the sleep apnea. If someone can't sleep because they're having joint aches and pains, well, then you need to address that.
It's clear that all these changes can lead to a strain on your relationship, not to mention how hormonal changes can often lead to decreased libido, change in orgasm intensity, and even decreased arousal. We talked a little bit about what women and their partners can expect and how they can maintain their sex life.
It's not just about what's happening in the vulva and the vagina, and we'll get there in a second, but it's also looking at big picture, because we talked a lot about cognitive function, but there's also mood changes, all this crazy ups and downs and snapping at someone, and it really does have a huge impact on relationship, not to mention if you're not sleeping. We also know, and we have very good studies that show that the greatest likelihood that someone is going to have sexual dysfunction, meaning either problems with libido, arousal, pain, orgasm, are women who have the worst symptoms. So while you don't think of your hot flashes and your insomnia as impacting on your sex life, It does. So you really need to address those things in addition to paying attention to the changes that are going on in the vulva and the vagina, and specifically in the vulva and vagina because they are loaded with estrogen receptors and testosterone receptors. What we know is that about 80% of women will experience vaginal dryness and thinning of the tissue, which for some women means that either sex is painful or impossible. And people think, okay, well, it's like hot flashes. This is going to go away. No, not only will it not go away, but over time, it's going to get much, much worse. And instead, though, women are not given appropriate information. They go into avoidance mode. They start to sabotage the relationship to avoid being sexual. But I will tell you the good news, and you know this because you do this too. The good news is number one, these things are 100% reversible. If someone comes in and tells me I'm having problems with libido, I'm having problems with this or that, usually I can help them. Hopefully I can help them. No guarantee I can help them. If someone comes in and says, ever since I went through perimenopause and menopause, I'm having dryness and pain with any penetrative activity, meaning penis, toy, whatever you're trying to put in there, that's reversible. And there's no time clock. It's not like, well, now you're 60. You should have talked to me 10 years ago. It doesn't matter if someone's 50, 60, 70, 80, 90. Those changes can be reversed at any time. And we have so many things that we can do. And people will like try a lubricant. And if that doesn't work, they're like, oh, well, I guess this is just a normal part of aging and I'm going to give up. When in fact, a lubricant is not going to help most people unless they only have very mild changes. And you might have to bite the bullet and get a prescription, but we have a lot of other things that we can offer.
One of the cheapest and safest ways to improve those genitourinary changes is by using vaginal estrogen.
A lot of people are not aware that there's many different options when it comes to, we call them vaginal estrogens, but it's really vulvar as well, because you have to treat both inside and outside. It's not just the internal stuff. And where estrogen cream is one option and generally the least expensive, we also have tablets, suppositories, rings, all kinds of different options. But by far, the cream for most people is going to be the least expensive. It is generally going to be covered by insurance. If it's not, you can go to Mark Tubin's site and get it for about, $10 a month or something. It's really very inexpensive and it's completely safe. When you look at the warnings on the label, that's what we call class labeling, meaning that the FDA put it there because of maybe estrogen problems from oral estrogens. But when we're looking at the topical stuff, this stuff can be used if you've had a blood clot, if you're worried about dementia, if you have breast cancer. It doesn't matter. And like you said, it works really well, not just for the sexual symptoms but the non-sexual symptoms, the bladder symptoms. That's your world, not my world. The urgency, the recurrent urinary tract infections, all of those things are going to be helped by using a topical vaginal and vulvar estrogen product. The other thing that a lot of people forget about is that it's not just estrogen receptors. There's also testosterone receptors in the vagina and the vulva. And those also contribute to all the good stuff, lubrication and elasticity and thickness of the tissue. And sometimes we do actually use a compounded estrogen and testosterone together, but there's a product that a lot of people may not be aware of called Intra Rosa is the trade name. I don't work for any of these companies, by the way. And Intra Rosa is DHEA. And DHEA is really interesting because it's the building block for both estrogen and testosterone. So this is a vaginal suppository that goes in daily, and it basically will kick your own vaginal tissue into action to make its own local estrogen and testosterone. So if there are women that say, I tried some vaginal estrogen and it really didn't help me, sometimes they need to kick it up a notch and use DHEA. To that point, a lot of women will say, well, you say it's 100% treatable. I used vaginal estrogen and it didn't work. And one of my most popular podcast episodes is I'm using vaginal estrogen and sex still hurts like hell, because there are other reasons that women can have pain with sex. And those are usually the reasons why vaginal estrogen is not going to solve the problem.
However, oftentimes the major issue is that women aren't using enough vaginal estrogen to get the job done.
You're absolutely correct. People get so nervous. They're like, "Oh, I'll just put a little bit on." And it's like, "No, slather it on, because if you use a little bit, it's not gonna do a thing."
Especially if you're having recurrent UTIs, it's important to use the right amount of vaginal estrogen. I often show my patients to take one finger, apply the vaginal estrogen cream to that finger, throw away that stupid applicator that comes with it, and apply this inside the vaginal canal, rub it in. You can also apply it on the labia minora, the clitoris, and the clitoral hood, because that can help maintain the estrogen in those tissues as well.
What you really wanna do is you wanna change the microbiome of the entire area. And the only way you're gonna do that is by putting estrogen inside the vagina. And again, if you're gonna talk about getting rid of painful intercourse, you need more than a pea size. You really have to treat the whole area, including the opening. The opening of the vagina is one of the most neglected areas. The medical word for it is the vestibule, the door to the vagina. And it doesn't matter how nice the room is if you can't get through the door. And too many women are given vaginal estrogen and are not told to apply the cream to the opening, which is a game changer for many people.
Dr. Stryker explained why orgasm intensity changes as we age.
It's very common. So let's start with that. It is the second most common sexual issue in postmenopause women. Libido is the first most common. But the inability to have an orgasm, or difficulty with orgasm, or it takes so long, or it's so much work that it's not worth it, is very, very common. And when you look at what it takes to have an orgasm, biologically, well, I have real good news for everyone. You do not need to have estrogen to have an orgasm. It helps, but estrogen is actually not on the pathway. What you do need to have an orgasm is, number one, you need to be aroused. Arousal meaning increasing blood flow to the genitals, including the clitoris. That's very, very important. You will not be aroused if you're having pain. So you must get rid of pain that's associated with sex if you want to become aroused and have an orgasm. So that's number one, why women have difficulty postmenopause, because if they're having pain with penetrative sex, then they're not going to be aroused. Number two is that as a consequence of aging, lack of estrogen, and medical conditions, which are more common in this time of life, such as heart disease and diabetes, the blood vessels that supply the clitoris are not going to be as healthy. Decreased blood supply is going to translate into nerve endings that are not as sensitive, less sensation, less likely to have an orgasm. So there's a lot going on, and certainly some people are at greater risk than others. Certainly diabetics are probably at the top of the list of people who have difficulty, but any woman can have difficulty. So the number one thing to do after you get rid of pain is you want to increase blood flow to the clitoris. That's critically important. So I said estrogen isn't necessary, but it sure helps a lot. So when you're putting estrogen in the vagina, on the opening to the vagina, hitting the urethra, go north. Go north and make sure to put a little bit of estrogen directly on your clitoris, because that's going to go a long way in terms of increasing blood supply. And I don't mean at the time that you're having intercourse. It's not a lubricant. I'm talking about on a regular basis to increase the health of your clitoris. You can get shrinkage of the clitoris. You take a look, and people should be looking, and you want the clitoris to be pink. You want it to be the size of about a Q-tip. You want the little hood over it to be able to slide over it easily. And if you look and it looks kind of small and pale, what that tells you is your clitoris needs a little help, needs a little estrogen love. So, little topical estrogen is important. There are a lot of other products that are being used, not a lot of data necessarily, but basically vasodilators, things that increase blood flow, that are used on the clitoris. Sometimes there's these compounded, they call them, arousal creams, orgasm creams, and basically that's what they are, is vasodilators. We talked a little bit about earlier, we were talking about cannabis. Cannabis is very interesting because, again, we don't have very good data, but we do know that CBD is a vasodilator. It increases blood flow. And while we don't have great science behind it, we do know that if you put a little bit of CBD oil on the clitoris, again, on a regular basis, that also might increase blood flow. So there's a lot of things we can do to make a clitoris healthy again and more responsive, because those nerve endings are going to be less sensitive. And that's also where vibrators comes in. We know that Sometimes you need to increase the intensity of the stimulation, but it goes beyond that because neurologically, it's really interesting that the nerve endings that respond to vibration are the ones that are not going to age as quickly. They're nerve endings that respond to licking and soft touch and stroking and all these things, which kind of did it for you in your 20s or 30s. And suddenly, if that's not doing it, that women who always had an orgasm with oral sex and all of a sudden nothing's happening, it's because those specific nerve endings are no longer as responsive. So obviously, if you're having sex with yourself, a vibrator should be a part of the experience. And if you are having partnered sex, then it comes down to what we call pairing, meaning that whatever you're doing with whoever you're doing it with, that a vibrator becomes part of the whole experience, and it will be a huge difference. So many women, I know, a lot of guys out there are listening, and so many women think that if they bring up that they need a vibrator in order to have an orgasm, that somehow the guy's going to be insulted. And quite frankly, it's the exact opposite. It's the exact opposite. Most men want their women to have a good time. They want them to have pleasure. They want them to have an orgasm. And instead of sitting there and fruitlessly going at it for, half an hour and hoping that she's going to have an orgasm, the guy should whip out the vibrator and say, what do you think about this? Do you think this would be fun? And then, just go for it. But guys also need to understand that women need clitoral stimulation. Some well-meaning guys will say, well, I'll get a vibrator and it sure sounds fine to me. And then they end up buying something that's long and hard and shakes a lot and goes internally. And that's not what women are looking for. They're looking for external stimulation. And there's so many of these couples vibrators now that are intended to be used during intercourse, because a lot of people, they want it to be part of the intercourse experience, which is fine, and they have things that are for couples and that are paired, or that you can, just little bullet things. And there's no end of fabulous options out there.
Interestingly, when we talk about women's health and men's health, it's often looked at like two very separate things. When men have difficulty with arousal, they have erectile dysfunction and they're treated with oral medications like sildenafil or tadalafil. However, women who have difficulty with arousal are treated with topical creams, arousal gels, or CBD. While there's some data on these oral medications for women, Dr. Stryker explains how the data is very limited.
So this is the thing. If you actually go back and look at these studies, and I have, they're pathetic. These are not good studies. They're old, they're small. It's, when you look at who does these studies are expensive to do. Well, the people who are motivated to do these studies are people that are developing or want to sell a drug. And no one is developing an oral PDE5 for women. So while there have been a few studies here and there, they're not very good. The results have been inconsistent. And in fact, the group that it probably helps the most are the women who lose the ability to orgasm from using an SSRI. And again, very, very little data. Anecdotally, I've seen in practice many, many times that women who are unable to orgasm with an SSRI are the ones that are most likely to respond to an oral PD5, either Viagra or Cialis. These are the women that come in and say, I was fine. And then I started my SSRI and it turned off like a light switch. With those women, I don't do anything else. I go right to a PDE5. I don't waste their time with doing this, that, and the other, because that's so clearly the issue, as opposed to someone who says, well, I've been taking my, Paxil for 15 years and all of a sudden I can't orgasm. It's like, it's not your Paxil. Forget that. That's not the issue. So certainly oral PDE5s have a place for women to use. The biggest problem with using them in women, particularly midlife or older women, is because we don't have good safety data for people who have heart disease or other medical conditions. It's very hard to comfortably to prescribe it because, first of all, there's plenty of side effects that have been seen in the men, as you know, and women are not little men, and you can't assume that what goes on with the men is going to be what goes on with the women. Now, there also is research that's going on with using topical sildenafil. And people have been doing that off label for a long time through compounding pharmacies. That's part of the arousal cream for a lot of people. There is a product which is now in phase 3 trials that sildenafil is going to be FDA approved as an arousal cream for women. But sadly, it is only being tried in premenopausal women, which is crazy because these are not the women that are having trouble. But this is not unusual in the pharmaceutical world, that it's easier to get FDA approval because these are healthier women for young women. And certainly when it becomes available, it can be used off label. But then you get into the insurance coverage stuff. So there is some research going on, but not nearly what we would like to see.
Previously on my channel, I've talked about the concern with heart disease and PDE5 inhibitors being very overly cautious. My general rule of thumb is that if someone can't have sex, meaning they haven't been told by their doctor that they can't have sex because their heart can't withstand the actual intensity of sexual intercourse, and they're not on nitrates, that generally it should be safe for using medications for erections, which makes sense because it's actually causing the blood vessels to relax and it actually increases blood flow to the genitals.
Well, originally it was for high blood pressure, and they just found that it was better at giving men erections than it was at controlling their. I think it was originally for angina and high blood pressure. It didn't work great, but it also didn't cause more problems, to your point. But it does always make me a little nervous to extrapolate that for women, particularly women who are older. That's the thing. If you're talking about giving it to a 30-year-old woman who's got great cardiovascular function, it's like, okay, it's unlikely that she's going to get into trouble. If you give it to someone who's 60 years old, it's very tricky. And we look to the things that we do have. But I will tell you, like I mentioned earlier, if someone comes in and their problem is vaginal dryness, I can help them 100% of the time. If their problem is they can't have an orgasm, I can usually do something that's going to help, between the vasodilators and using a vibrator and some of the other things that we can do, but it's not a guarantee. We need more work.
Dr. Stryker ended the podcast by sharing with us what she's working on now.
I have a new podcast series called Come Again, which is about orgasm. I've had a podcast for a long time, of course, my Menopause Midlife and More podcast. And that's more general stuff about menopause and midlife. But I decided to do a podcast series that was specifically about peri and post menopause arousal and orgasm problems. And the reason I decided to do that is because while a lot of women are able to get help in terms of their hot flashes and insomnia and a lot of the other things they've talked about, when it comes to the inability to have an orgasm or to become aroused, they're not getting a lot of help from their doctors for this very, very common problem. So I thought, okay, I'm going to do a series that is just about that. So this is a limited series podcast. It's 30 episodes total. Part 1 is 15 episodes, which is all about orgasm and what can go wrong and what could possibly happen and who's at risk. And then Part 2 is all about solutions. So I have an entire episode on the SSRIs, another episode on why, the physiology behind vibrators, how to make your vibrator work. We touched on vasodilators. I go through all of that. So it's quite unique in terms of it being a really comprehensive masterclass in postmenopause orgasm. And I'm very excited about that.
We ended off with our final 4 questions. Is there something you know now in life that you wish you knew earlier?
Oh boy, I have a very long list of things. I think, really the thing that I appreciate now at this point in my life is you don't have to figure out what you want to do when you're 20. And most 20-year-olds feel like this is it. They have to decide what their life goal is going to be. And if I think of all the pivots along the way and all the different things I've done, starting from being an English major and thinking I was going to be a ballerina, and then ending up in medical school, and then starting off doing, mostly general stuff, and then being mostly interested in surgery, and then pivoting to menopause and sexual medicine. And I think that's really the life lesson, is that everything you do is valuable and is going to contribute, but the path is going to keep winding and changing, and you just have to go with it.
What's a non-negotiable, something you have to do every day?
You know what? I really need to move in some way. And that's really important to me. And even if I have a day which is really an intense work day and I know I'm not going to leave my desk, I work on a treadmill desk. I am walking or moving all the time. I give myself breaks to even do something ridiculous like, jump up and down or do squats, because it's not just about being fit, which I think is important. It's just about, for a minute, getting out of my headspace and getting the blood flowing and getting a little bit different energy level. So every day, whether it's getting out and walking or riding my bike or on my treadmill desk, I have to find a way to move.
What's a life hack or health hack you would share with our audience?
Oh, I did a whole podcast on gynae hacks, most of which you've never heard of. They're all on YouTube. They're all on Instagram. But the one I will share with you, because I think it's so critically important, is women do not look at their vulvas. They do not. And men, of course, can look at their penis and inspect their penis with absolutely no effort on their part. But for women, it's a little trickier. And they're also often taught that it's nasty down there. Don't look. So they don't know their own anatomy. And then if they do decide they want to take a look, it's not so easy. The flashlight, the mirror, the getting in position. So I came up with a hack that you can get a hands-free vulvar view. And it's actually quite simple. And again, it's on YouTube. You can find it easily. Dr. Stryker's hands-free vulvar view hack. And basically, it's a way to kind of wedge a mirror in on the toilet seat and position it so that you get the money view and you've got your hands free with a light attached to it and the whole thing. So that's my hack that helps women really, really get to know their own anatomy. And it was actually something that was originally someone who did that to help women self-catheterize from the urology world so that they could see their urethra. But it's also a great way to get a vulvar view. So that's my hack. And I won't even get into the electric toothbrushes vibrator hack because everyone who listens already knows that one, right?
Make sure you don't lose it. And finally, if you couldn't be an OBGYN, author, podcaster, what would you be?
Oh, I would have been a ballerina. Absolutely. I'm an absolute passionate ballet person. It's what I wanted to do growing up. I didn't have the body or the talent, so I would have loved to have been a ballerina. And second, of course, is I would have loved to have been a musician. I love music. I was hoping at some point that if ballet wasn't going to be my life, that maybe be a pianist, but I also didn't have the talent for that. But it's something I enjoy. And then journalism. I did start off in journalism. I thought I was going to be a journalist before I went to medical school. And then here we are full circle. Now I'm writing again.
Dr. Stryker left you with some details on where to find her on social media and online.
I want people to listen to Come Again, because I think that is going to be, for a lot of people, more help than anything else. And also Substack. I'm on Substack. I'm doing a lot on Substack. I love Substack. And almost everything we've talked about, I have an article on Substack, or there will be one coming.
Did you know that the majority of you listening and watching my content are not subscribed or following me on your podcast platform? If you're enjoying what you're learning, please hit that subscribe button or follow the podcast. It's a great zero-cost way to support the podcast. Thank you for listening. If you enjoyed this episode, don't forget to leave a rating or review on Spotify or Apple Podcasts. And as always, take care of yourself because you are worth it.